Okay, good afternoon, everyone. Thank you so much for joining us. It's about that time to start our afternoon session. My name is Amit Grover. I'm one of the pediatric gastroenterologists at Boston Children's Hospital. And I have my colleague here, Mustafa. Why don't you introduce yourself?
Hi, my name is Mustafa, and I'm a gastroenterologist at Advent Health in Orlando.
Thank you so much for coming for this session today that we are entitling, or that has been entitled Chronic Pancreatitis, Current Guidelines and Standards of Care. We have an excellent lineup. And we'll start off with our first speaker, Mustafa.
Yes, we have with us Dr. Diraj Yadav, who really does not need any introduction. He's a professor of medicine at the University of Pittsburgh and eminent sort of personality in the field. We look forward to Diraj's topic, which is long-term prognosis of chronic pancreatitis.
Thank you, Mustafa. This session is titled Chronic Pancreatitis Current Guidelines and Standards of Care. And my assignment is to talk about long-term prognosis of chronic pancreatitis. This is a very broad topic. I'll touch only on some aspects of it, specifically with an eye to the future. So for any chronic disorder, when we think about long-term prognosis, there are two considerations. One is overall survival, and second is disease-related morbidity. In terms of overall survival for chronic pancreatitis, several studies have documented that the overall survival in patients with CP is lower as compared to expected in the general population of same age and sex. What you see here in the graph is one example of a population in Olmsted County, where after the diagnosis of CP, the median survival was around 12.5 years, and the mortality was about 2 times greater as compared to expected. Couple of other important things here are to note is that most of these patients, or when we think about survival, we focus on patients who have alcoholic pancreatitis or late onset idiopathic disease, and not much attention to those who have early onset disease. Secondly, most patients with chronic pancreatitis, they die of with chronic pancreatitis, then from chronic pancreatitis, with 75% mortality from other causes. When we think of early term or long-term survival in patients who have early onset disease, these are data from 2 studies. In the left panel is a study from Denmark, where patients who are diagnosed between 1980 to 2004 and followed till 2008. If you look at the Kaplan-Meier curve, the median survival is well over 20 years, even in patients who had alcoholic pancreatitis. But specifically in non-alcoholic pancreatitis, the median survival is much greater than that. Secondly, in the right panel is data from PRSS1 patients, symptomatic and asymptomatic, enrolled from the University of Pittsburgh over 20 years, where the expected survival is very similar to the general population. The importance of this is that patients who have early onset disease, in these patients, morbidity related to chronic pancreatitis is extremely important and a focus for us to think about. When we think about morbidity in chronic pancreatitis, again, numerous studies have documented that, and this is data from patients who are enrolled from UPMC in the NAPS2 study. Abdominal pain being most common, present in 90% patients, even at a median follow-up of about 12 years from onset of initial pancreatitis, about half of these patients continue to have pain, very high use of narcotic medications, high number of pancreatitis-related admissions, diabetes, exocrine insufficiency, and about 2/3 patients need some form of intervention during their clinical course. So if we have to think about improving long-term prognosis in CP, what are the strategies that we can think about? The first is to address the comorbidities, because that's the most important reason for overall mortality. But this is something that is outside the realm of us as gastroenterologists or pancreatologists. This is for the primary care physician and specialists who are seeing the patients for other reasons. As pancreatologists and gastroenterologists, we can focus on behavior modifications when it is indicated and think about pancreatitis-related outcomes that we can focus on. And the graph on the right side shows that as compared to what the expected outcomes on for these patients should be, our aim is to have desired outcomes, which is lower than what it is in a population of patients. So how do we do that? When I think about this specific situation, I can think of two different ways we can address it. One is by increasing awareness of healthcare professionals for best practices in longitudinal care of patients. This is an area that actually does not apply only to CP, it applies to all chronic disorders. Because many primary care physicians and GI physicians even, they are not aware of what the expected clinical course of these patients would be, and also what is the rationale for us in making clinical decisions. And this is important. And many of these questions, specifically for increasing awareness, very difficult to test empirically. Second is to optimize treatment for pancreatitis-related outcomes. And we can do that by integrating new discoveries into management algorithms and developing therapies to favorably alter the natural course of disease. This last particular topic is something that we feel is very difficult because we don't have any treatments at this time. But for us to put our thoughts together in this area is very important, because once we are able to conceptualize what the expected outcome will be in a group of patients and predict it, that will allow us to think about how we can improve it going forward. And I'll give some examples. So this is an example from a study from the Dutch Pancreatitis Study Group, where they looked at a subset of patients who were enrolled in the care cohort, and they looked at the records of patients to see how often the UEG guidelines for non-invasive management was followed in these patients. And on an average, each subject was eligible for about 26 guidelines. And what they found is that guidelines were followed in only 53% of patients. And this was not affected by age of the patient, sex of the patient, etiology of the disease, or the setting in which the patient was seen. So again, there's a huge margin for us to do better for the things we already know that are helpful for patients. Giving you some examples, this was a very nice study from Spain, where they followed patients, 430 patients with chronic pancreatitis for an average of 10 years. And what they found is that patients who had exocrine insufficiency, the mortality in these patients was twice as compared to patients who did not have exocrine insufficiency. That's highly important after controlling for age, demographic, other demographic factors, etiologies, and other comorbidities. And why is this important? We looked at data in a national claims database in the United States, and we found that among patients who have chronic pancreatitis diagnosis, less than 10% get tested for exocrine insufficiency. The rate for PERT prescription is only in 1/3 of patients. And very importantly, of the patients who receive PERT, only 1/3 got appropriate dosing for PERT. So there is a huge margin for us for improvement. Another example that is in context to today's discussion is osteopathy. And these are the first data that has been published from the longitudinal cohort study PROCEED from the CPDPC consortium, headed by Phil Hart and Darwin Conwell, who led this project. Among the 282 patients with CP in this study who underwent a DEXA scan either clinically or for research purposes, the prevalence of osteopathy was 56%. And if you look at the figure on the right, in men, we don't even think about osteopathy, but 40% men with CP had osteopathy, 12% had osteoporosis. And even in subjects who are less than 40 years, 30% of them had osteopathy. Why is it important in the context that I'm talking about? Because low BMI was the single most important reason or association for osteopathy with an odds ratio of 7. The second way to think about it is to incorporate new knowledge. And this is example from a study for a 3-center collaboration, UPMC, Johns Hopkins, and Aalborg University. In 171 patients with standardized measures, we assessed for prevalence of anxiety and depression. The psychological comorbidities were present in about 50% patients. And patients who had severe pain or constant pain had even higher prevalence than the other patients. And as you can see on the radar plot on the right, patients who had psychological comorbidities had lower quality of life in pretty much every domain. What is the implication of that? Well, we can always discuss about the cause and effect phenomena, The implication is if a patient with chronic pancreatitis has psychologic comorbidities, adjunctive treatments could actually be beneficial in addition to the standard treatment that you're giving for pain. And one example of this would be cognitive behavioral therapy. So this is again a study from the CPDPC consortium that was led by Dr. Tanya Palermo from University of Washington. Patients who had suspected or definite CP who had pain, they were assigned to internet-delivered CBT versus usual treatment. And patients who received CBT, they had significant reduction in pain, more than 30% or more than 50%. And these promising results have now led to development of a larger definitive study. Now moving on to pancreatitis-related outcomes, this is a conceptual framework called Holistic Prevention of Pancreatitis Model. It organizes chronic pancreatitis into stages where we can start thinking about ways for primary prevention, secondary prevention, and tertiary prevention of disease. For chronic pancreatitis, primary prevention will be preventing progression from AP or RAP to CP. Secondary prevention would be slowing CP progression, and tertiary prevention will be to prevent progression to sequela of CP. Now, there are many ongoing natural history studies in CP, two from the CPDPC consortium, one in adults called PROCEED, and one in pediatric patients called INSPIRE-2. The Dutch pancreatitis study group has the CARE cohort, and the Danish group has the PANFib study. And then a unique study called POST that is led by Manila Bellin is patients who have had TPIAT, an observational study for longitudinal outcomes. A few words about the PROCEED study. This is the first longitudinal cohort study in the United States, which organizes a cohort of patients using the mechanistic definition of chronic pancreatitis from normal to suspected CP and definite CP. We are in the 5th year of the study, and we have enrolled around 88% of the cohort and established a biorepository. What we are conceptualizing is that we'll be able to do cross-sectional analyses for different stages of disease in a variety of ways, and then do longitudinal evaluation of these patients over time. In context of today's discussion, this could allow us to develop new models for assessing disease progression that could be beneficial going forward. So to summarize, overall survival in CP patients is decreased as compared to background population. CP is associated with high morbidity. There are several strategies that we can use to improve long-term prognosis in patients with CP, and the ongoing cohort studies will inform the development of new models to monitor disease progression. Thank you.
Thank you, Dheeraj. That was an excellent talk. We're going to hold questions until the end when we'll have the panel come up. It gives me great pleasure to introduce our next speaker, also who actually doesn't need any introduction at all, is Dr. Roger Little, is a professor of medicine at Duke University and former president of the APA. And he will be speaking to us entitled Update on the Pathogenesis of CP.
Great, thank you very much. I wanted to make just a few observations this afternoon about the pathogenesis of chronic pancreatitis. How do I advance this? Top green. Okay. All right, thank you. So the three major causes of chronic pancreatitis are shown here, and unfortunately, alcohol remains the most common cause of chronic pancreatitis. I'd like to introduce the idea, though, that duct obstruction, pancreatic obstruction, plays a major role in the pathogenesis of multiple forms of chronic pancreatitis. And we've learned a tremendous amount about the biology of chronic pancreatitis through genetics discoveries. And I'll use some of those as an example for exploring these topics. Chronic pancreatitis arises from primary damage to the acinar cell, and this can occur through a number of direct ways in which there may be physical damage, there may be oxidant stress, There can be mitochondrial dysfunction, and I think mitochondrial dysfunction plays a primary role. And we talked about, well, Peter Heggie mentioned that in his talk earlier today. And then there are calcium overload has been well described, particularly by David Criddle's group, and the role of alcohol in calcium overload, ER stress, defective autophagy, abnormalities in pancreatic enzyme secretion, and protease activation, and Miklos discussed this very nicely yesterday. Now, there are indirect mechanisms, and by that I mean primary duct problems, such as duct obstruction, alterations in pancreatic fluid pH or fluid volume. And then, of course, there's an inflammatory response, and this may be instrumental in, say, autoimmune pancreatitis. And the other major cell type in the pancreas, other than exocrine cell type, besides acinar cells and duct cells, of course, is the pancreatic stellate cell. And this is the cell that's responsible for pancreatic fibrosis. And the quiescent stellate cell is activated through a number of mechanisms, including cytokines that may be released locally, including TNF alpha, again, oxidant stress, and ethanol metabolites. So the genetic mutations that we have learned a lot about are briefly summarized here, and this is not an exhaustive list, but simply as an example. But mutations in the cationic trypsinogen gene, SPINK, the trypsin inhibitor gene, chymotrypsin C, all have implications for primary roles affecting protease activation. And that has been complemented by subsequent studies characterizing, say, CFTR, which is responsible for a good percentage of patients with idiopathic chronic pancreatitis, and the calcium sensing receptor, which have primary abnormalities exhibited on the duct cell of the pancreas, and this can result in reduced fluid secretion, the impairment in acidification of pancreatic juice, as well as protein precipitates that may contribute to duct obstruction. Of course, carboxypeptidase A has been implicated in ER stress. Claudin has been implicated in a primary effect on the inflammatory cell. Now, if we look at alcohol as the major cause of chronic pancreatitis, it's almost overwhelming when you look at the potential mechanisms whereby alcohol can affect the pancreas. And this some of these effects are mediated by alcohol metabolites, such as acetaldehyde. David Criddle and the Liverpool group has done an outstanding job in characterizing fatty acid ethyl esters as a primary mechanism for inducing calcium overload that contributes to pancreatitis. And so these are, again, mechanisms that may affect directly on the acinar cell, but they also have effects on the duct cell. So alcoholic pancreatitis patients have an increased concentration of protein in their pancreatic duct, which may contribute to pancreatic duct obstruction. And there are alcohol metabolites that directly affect pancreatic stellate cells and can lead to stellate cell activation and subsequent fibrosis. So I have been struck for a long time by the observation that it's extremely difficult to produce pancreatitis in an animal by feeding that animal alcohol. So alcohol alone rarely, unless you do something quite extraordinary, does not cause pancreatitis. This is an example of feeding alcohol to mice who has a perfectly normal appearing pancreas. However, this may be modified by manipulating the diet. And we observe that putting animals on a low phosphate diet that in and of itself does not affect the pancreas. It certainly does not cause pancreatitis, even though it lowers serum phosphate levels. when you add alcohol to animals on a low phosphate diet, they get a resulting pancreatitis that's manifest by all of the typical features of pancreatitis that we normally expect to see, with pancreatic edema, elevations in pancreatic enzymes, neutrophil infiltration, and obvious changes in histology. Now, this is due to the low phosphate concentration, in that it can be reversed by treating animals replacing them with phosphate. And so putting animals on a low phosphate diet, adding alcohol causes pancreatitis, and this can be prevented by administration of phosphate, and it lowers all of the parameters that we would normally see. We think this occurs through effects on mitochondrial function in generation of ATP. So animals on a normal phosphate diet treated with ethanol maintain good mitochondrial function. This is manifest by maintaining their mitochondrial membrane potential. However, when they are on a low phosphate diet plus alcohol, the mitochondria lose their ability to generate ATP. And again, this can be restored by adding back phosphate. And here is the ATP content in the pancreas in animals on a low phosphate diet with and without alcohol. And this can be restored by restoring the ATP levels by replacing phosphate. The other point that I want to make is that looking at the morphological features of chronic pancreatitis of various etiologies, and here I've thrown in even tropical pancreatitis, autoimmune pancreatitis, and other idiopathic causes of pancreatitis. One looks at the pancreatic duct, they are abnormal. They either have subtle irregularities or stenosis or frank dilation. Now you may say, well, that's simply a result of their pancreatitis, and that may indeed be the case, but I would suggest that perhaps the pancreatic duct abnormalities may contribute to ongoing pancreatitis. And of course, all of these causes of pancreatitis are associated with pancreatic fibrosis. So I'll just conclude by introducing the concept that perhaps that duct obstruction contributes to pancreatic pathology, and it may occur through the force that's exerted through duct obstruction. And that can be either small duct obstruction or large duct obstruction. So we've had the opportunity to investigate this. It came about by trying to understand how the pancreas was so sensitive to pressure. And we identified that the mechanically active ion channel piezo is the most abundant mechanoreceptor in the pancreas. This is a very large membrane protein. It's 2,400 amino acids, and it possesses this 3-blade-like structure that floats in the plasma membrane, and it's a cation permeable channel. So that activation of the channel by deforming the plasma membrane can open the channel that is primarily permeable to calcium ion and has the ability to increase intracellular calcium concentrations. And I'm not going to show you those data because Sandeep Swain in our group is going to be presenting an abstract in the session immediately following this one, and he will explain how this may contribute to chronic pancreatitis. So I've tried to provide just a few insights into the pathobiology of chronic pancreatitis, and I would suggest that central to these mechanisms in many causes of pancreatitis is not only going to be the contributions of duct obstruction and pressure, the genetic manifestations, and alcohol itself seem to be mediated in large part by abnormalities in mitochondrial dysfunction. And I would suggest that might be a strategy for attacking multiple abnormalities that that occur as a result of multiple different insults, in maintaining the energy sources within the acinar cell may be a strategy for at least preserving some remaining acinar cell function, regardless of when and how pancreatitis begins. So thank you very much. I appreciate your attention.
Thank you, Dr. Little. Our next talk is actually a virtual talk by Dr. Rupchayoti Talukdar. He's a director of the Pancreatic Institute of Pancreatic Asian Institute of Gastroenterology in Hyderabad. He's also the director of the Pancreas Research Group there. So this will be a virtual talk, and we can get started on that.
A very good afternoon. At the outset, I'd like to thank Professor Saluja and the organizing team for this kind of invitation. In the next 12 to 13 minutes, I'll take you through some of the aspects of nutritional management of chronic pancreatitis. Now, let me begin with the story of baby Annie. She presented to our pancreas clinic in June 2012. And she had a diagnosis of chronic pancreatitis in 2010, but she had been suffering from the symptoms since 2 years earlier. Her BMI presentation was around 15, and she was deficient with several micronutrients, and cross-sectional imaging showed a little bit of pancreatic atrophy. The duct was 6 millimeter, while there were no stones within the pancreatic duct. She received treatment of pancreatic enzyme of 10,000 units after meals for the past 2 years, and she was on a fat-restricted diet. This is a prototype of chronic pancreatitis, and in this kind of a clinical scenario, pancreatic enzymes are usually started as if in a reflex manner. The golden rule of the thumb for pancreatic enzyme replacement therapy is its use in the right timing, the right preparation, and the right dose. So when I talk about right timing, there are a few studies that have shown equal efficacy if whether the enzymes are used along with food, before food, or just after food. But in clinical practice, what we see is the patient is most compliant if they take the enzyme preparation along with food. And this is important because it's essential for the enzyme preparation to be delivered in the duodenum along with the food chain for proper mixing and optimal action. Enteric coated microsphere or mini microsphere is the right preparation because the enteric coating is important for protection of the enzyme from gastric acid degradation. And the microsphere or mini microsphere, by virtue of its size of 2 millimeter or less, enables the passage of the enzyme through the fibrous channel along the food chain. But the most contentious question is the right dosage. And I think we still do not know the accurate dose and the right method to figure out what doses the patient will require. And there are several ways that can be done. One of them is to use the pancreatic physiology. So the daily pancreatic lipase output is around 600,000 units, out of which 10% is required for digestion. So that makes the daily requirement of pancreatic lipase of 60,000 units that can be split into different dosage. With that logic, starting dose of 25,000 to 40,000 units of lipase per meal appears reasonable. The recent European guidelines have recommended 36,000 to 50,000 units of lipase per meal and half the dose with each snack. And the even more recent ACG guidelines recommend 40,000 to 50,000 units of lipase per meal. And the other way of looking at it is in a per kg body weight manner, in which 500 units of lipase per kg body weight along with meals can be prescribed, and half the dose can be prescribed with snacks. But if we look at pancreatic enzyme replacement therapy closely, there appears to be several problems. Most of the studies test this enzyme replacement against a fixed calculated dose of fat diet of 100 grams of fat per day. But in the real world, usually patients with chronic pancreatitis won't take 100 gram of fatty diet per day. Most of these studies evaluate the non-clinical outcomes like the coefficient of fat absorption, coefficient of nitrogen absorption. And most of the studies are having a very short follow-up, on average of 2 months. There are 2 studies actually which had extended the follow-up till 6 months, and they also looked at some of the nutritional parameters, but a careful look at the study shows that these were industry-sponsored studies, and it appears that the sponsors were involved in the data analysis and paper writing. So I think the data from these studies needs to be revalidated in an independent manner. Till date, there are no studies that have evaluated the so-called entity of subclinical pancreatic exocrine insufficiency. And again, there are no studies that have evaluated the preventive role of PERT for the complications of the disease. And if we look at the results, they appear overall they appear variable across different studies. So if we consider this meta-analysis that was published in 2017, overall there was an improvement in fat and protein absorption. So most of the studies did not deal with the clinical outcomes. However, 2 more recent randomized controlled trials, one for post-operative patients undergoing Whipple's pancreatic duodenectomy, and the other for inoperable pancreatic cancer, the pancreatic enzyme replacement therapy failed to show any benefit in the nutritional parameters. And the final problem is the cost of this preparation, which is prohibitively high for a whole lot of patients, and in countries where insurance do not cover this enzyme, many patients end up being non-adherent to the treatment. Now, if we look at the pancreatic exocrine function, it is needless to say that pancreatic lipase is the single most important enzyme for dietary fat digestion. Even though there is an enzyme called the gastric lipase, this function of this is practically very minimal. However, for dietary starch digestion, it is the salivary amylase that plays a greater role than the pancreatic amylase. And for dietary protein digestion, along with pancreatic proteases, the gastric acid and intestinal proteases play an equally important role. So if a patient with chronic pancreatitis presents with protein calorie malnutrition, one has to consider that something beyond pancreatic enzyme replacement is going on. So let us see what happens in real life clinical practice. So this was a study that we have published recently, where we enrolled nearly 500 patients with chronic pancreatitis. And we divided the patients into 3 groups, namely the group A had patients who took at least 25,000 units of enteric-coated lipase along with meals for at least 3 months. In group B, the patients were taking the enteric-coated lipase for at least 3 months, but they were not compliant with respect to dose and duration. And patients in group C were either not started on PERT, and for those who initially were treated with PERT were eventually discontinued for over 3 months. And malnutrition was evaluated using the subjective global assessment. So if we look at the results, the proportion of patients who had malnutrition were similar irrespective of the status of intake of pancreatic enzyme supplementation. And the proportion of patients who were taking pancreatic enzyme replacement therapy was similar irrespective of the degree of malnutrition. Similarly, the proportion of patients who had weight gain or weight loss were similar irrespective of the status of pancreatic enzyme replacement therapy. So when we looked at the dietary intake, calorie deficit was similar for patients who were taking PERT compared to who were not taking PERT, but it was significantly low in patients who had malnutrition. Similarly, the dietary fat, protein, and carbohydrate intake were similar irrespective of the status of PERT, but was significantly low in the patients who had malnutrition. So when we looked at the possible risk factors using logistic regression, it turns out that the patients that low caloric intake and alcohol consumption were independent risk factors that were associated with persistence of malnutrition even after ERT. So even though pancreatic enzyme, pancreatic exocrine insufficiency and maldigestion are considered to be the major factor for malnutrition, it also appears that poor oral intake is also an equally important factor for malnutrition. And why do this patient eat less? One of the factor is that they are advised a fat-restricted diet, even though the guidelines do not recommend that. Many of these patients would not eat because of fear of pain. Chronic pancreatitis is associated with anxiety and depression, which could lead to poor oral intake. And of course, they have poor appetite, which results from inflammation, delayed gastric emptying, or substance use. And to top this up are the factors of the hypercatabolic state because of recurrent inflammation, presence of diabetes and the complications, neuropathy, and small intestinal bacterial overgrowth and oxidative stress. So all these factors as a composite would be responsible for malnutrition. Therefore, nutritional evaluation has to be done in a holistic manner using a multidisciplinary approach where the clinical, anthropometry, and biochemical assessment should be done. And also at some point in the disease course, sarcopenia and bone marrow density should be evaluated using DEXA scan and abdominal CT scans. Pancreatic enzymes are responsible for absorption of several micronutrients, but there are other micronutrients which do not require pancreatic enzyme for absorption and digestion. And moreover, several of the micronutrients gets used up in the oxidative stress of chronic pancreatitis. So even if the patient do not have overt pancreatic exocrine insufficiency, many of them could still have deficiencies of these micronutrients because of poor oral intake. So these has to be supplemented early on in the disease course. And this study from New Delhi had compared dietary counseling on normal home cooked food with dietary supplements, and it turned out that both of them are similar in improving the nutritional status of this patient. So here comes the importance of dietary counseling for these patients. So to summarize on how to improve nutrition in CP, the diet regimen should for this patient should be inclusive and not restrictive. A balanced, small volume, frequent feed is important, and more importantly, without fat restriction, especially if the patients are on enzyme replacement therapy. The diet regimen should be customized and personalized rather than using a diet based on a predetermined formula or a predetermined dose. If a patient is grossly malnourished and oral feeding do not reach the calorie requirement, they can be given a short course of occasional feeding. Micronutrient supplementation, adequate glycemic control, cessation of substance use are important, and this patient should be counseled and educated every step regarding the nutritional management and disease management as a whole. So finally, coming back to baby Annie, so when she visited our pancreas clinic, we started her an antioxidant cocktail, nutritional supplement, and counseled her to take a normal home cooked diet. And this is how she looked after 3 months. Her BMI increased to 20, and she did not have any fresh symptoms. So we stopped her pancreatic enzyme replacement at this point and continued the antioxidant cocktail and the home cooked diet. And she continued to improve in her nutritional status even without pancreatic enzyme, only on home cooked diet. And of course, in January 2015, she came back with pain. At that time, we detected stones in the main pancreatic duct, and she also had hypothyroidism. So we had to subject her to as well and treated her for the hypothyroidism. And this is how she looks now, without any gross symptoms. She's not on any pancreatic enzyme, not on any antioxidants. She's just on normal home cooked diet and has been taking thyroid replacement. So finally, I'd like to close my talk and I'll be happy to take questions. Thank you.
Excellent. We will move on to our next speaker, who is Dr. Walter Park, who is the medical director of the Benign Pancreas Program at Stanford Healthcare. And his talk is entitled today, EUS in the Early Diagnosis of Chronic Pancreatitis. Are we ready for prime time?
Thank you. And it's a real pleasure to be invited to be a part of this symposium, particularly to share this podium with Diraj, Roger, and Roop, all people who I have a tremendous amount of respect for. So I've been assigned in the symposium under guidelines and standards of care to talk about EUS, and the title that was given to me was Ready for Prime Time. So there's already some implicit assumptions here, and even in the use of the title, suggesting that it isn't. And so I'm gonna basically make some assumptions about this audience as well, given the short time frame that this is a self-selected audience. You're obviously here, you're pancreatologists, many of you, you're familiar with the EUS literature. So I'm not gonna kind of delve into the basics of EUS and how it's used, but kind of go over where we are with the current guidelines and inject some of my thoughts about this discussion or this question of whether it's ready for prime time. For this particular talk, I have no relevant disclosures. So I think Diraj and Roger laid out nicely our paradigm that chronic pancreatitis is a progressive chronic inflammatory followed by fibrotic disease, and that there are significant complications as this disease progresses, including exocrine pancreatic insufficiency, diabetes, chronic pain, and in some cases, pancreatic ductal adenocarcinoma. And the idea or the assumption here is if we can detect it at an earlier stage, there may be opportunities to alter the natural history, these morbidities. And so again, this is the figure that starts with the general paradigm here is we have a normal pancreas. Over time, we have episodes of acute pancreatitis followed by recurrent acute pancreatitis, irregardless or independent of the etiology. And on the far right, you have essentially advanced chronic pancreatitis. And implicit in this concept is that there must be, if you assume linearity here, that there is a stage of early CP, early chronic pancreatitis. And then the question is, what does that look like? How do we know we have a patient with early CP? And I think that's really the essence of what we're trying to get for the purpose of having interventional strategies or to alter the natural history. And so on the top line is where is our current imaging in capturing this natural history? Well, we know that CTs are great at diagnosing calcifications and dilated ducts. But it's not accepted as a widely sensitive tool unless there's been further iterations perhaps in the future. We think that MRI and MRCP can do a better job, particularly looking at maybe Cambridge 1 or Cambridge 2 and capturing that, particularly its T2 MRCP signaling. Maybe with secretin function testing, we can, we kind of see it maybe as capturing a little bit earlier. And then the question is, where does EUS fit on this? And I think at one point, thought was in the concept of the controversial minimal change disease that perhaps EUS fits even earlier as the most sensitive test. So in this context, I'm going to kind of go over the guidelines. But before I do that, this is just a rehash of kind of what are those criteria of EUS features that we have correlated over time with chronic pancreatitis. And there are, as many of you know, parenchymal features and ductal features. And it should be, and I don't think there is data that does show that it correlates to histology. So when we do see hyperechoic foci or hyperechoic strands, it does correlate to focal fibrosis and bridging fibrosis or interlobular fibrosis. And this, again, is consistent with our models of inflammation followed by fibrosis. So in that sense, this has given rise to this would advocate for the idea that, with an EUS scope being the closest probe to the pancreas, giving the closest views, this in theory offers the most sensitive imaging and therefore has the greatest capacity to find early chronic pancreatitis should we see it. Okay, so with that kind of mindset, where do our guidelines sit? And so this is going to be just a brief walk kind of, in history. We go back to 2014, and these were the evidence-based statements about the role of EUS. And basically they said, okay, with these criteria, the ideal threshold, the number of EUS criteria necessary to diagnose CP has not been firmly established, but the presence of 5 or more or 2 or less strongly suggests or refutes the diagnosis of CP, and that the EUS features of CP are not necessarily pathologic and may occur as normal aging, as a normal variant, or due to non-pathological asymptomatic fibrosis in the absence of endocrine and exocrine dysfunction. These are basically quotes from the guidelines. And then in addition, the other Achilles heel is the poor inter-observer agreement for EUS CP features, which limits the diagnostic accuracy, the face validity, and the overall utility, therefore, of diagnosing CP by EUS. And the conclusion is that if you are going to use EUS findings, then you need to correlate it with clinical, structural, and functional analyses to make a possible diagnosis of early pancreatitis, chronic pancreatitis. 3 years later, the UEG did their own evidence-based consensus statement, and here they state statement 2.1, EUS and MRI and CT are the best imaging methods that we have for establishing the diagnosis, and that in statement 2.9, we've concluded that EUS is the most sensitive imaging technique for the diagnosis of CP, mainly during the early stages of the disease, and its specificity increases with increasingly diagnostic criteria. And when compared to histology, EUS has a sensitivity greater than 80% and a specificity of 100%. And there's excellent correlation between the number of EUS criteria present and CP severity with respect to histology. And these are the guidelines consensus from the Europeans. ACG 2020, basically, they take a slightly different bent. My colleagues, Tim and the authors say that we recommend CT or MRI for first line, and either test should be the first choice for the diagnosed CP, primarily because EUS is invasive, and because it's lacking in specificity, it should be used only if the diagnosis in question after CT and MRI is performed. Not quite clear what in question they would pursue. But basically that they acknowledge from their review of the literature that EUS is comparable to MRI, CT in sensitivity and specificity of CP, and that it could be used if there is a concern for minimal change disease that cannot be seen by CT. But they also said that they, like the other guidelines, no specific criteria or number of criteria can be recommended at this time. Now, the Japanese diagnostic criteria in 2019, what I like about this particular criteria is that it actually attempts to go forward and come with some type of algorithm that does follow through on the sentiments of the APA guidelines of clinically correlating to morphology. And basically they have this algorithm that basically kind of, if you walk it down, you essentially have no signs of characteristic images of chronic pancreatitis. And then they say if you have these clinical features plus some of these EUS features are greater than 2 out of 4, including lobularity, hyperechoic foci, or strands without shadowing, dilated side branches, or hyperechoic MPD, then from a standardization perspective, we're going to make a claim that this is perhaps early CP for the purposes of consensus. Finally, given the numerous different guidelines across various different oceans, there was a consensus guideline from the IAP-APA, this very own organization, the EPC and the JPS in 2020 that basically said there was strong agreement. And this kind of goes back to the original APA guidelines that there is no ideal threshold. And they kind of take the same statement from the APA 2014 that you can't, that 5 or more or 2 or less is suggestive, respectively. They do make a comment that, yes, we acknowledge that there has been an attempt to standardize and weight certain features more than others through the Rosemont scoring. However, it has not appeared to demonstrate an overall improvement versus conventional scoring. And that, again, specificity, intra-observer variability, and pretest probability remain the Achilles heels for the utility of diagnosing EUS. So I think what I hope I've kind of conveyed to you at a high level is that no one really disputes that EUS is a sensitive modality. that it does potentially have a role, that it is widely used, but yes, it does have flaws and limitations like any diagnostic tool, in that there are patients who have morphological findings, maybe due to age or smoking, and in the absence of clinical correlating features, we're not sure what this really is, and maybe this is a pancreatopathy. I would submit that that's no different than even MRI and CT. For those of us in referral pancreas clinics, we get patients referred from outside doctors of a patient with a calcification, but no clinical history or risk factors of chronic pancreatitis. We could probably say the same thing. This patient doesn't have chronic pancreatitis because he doesn't have clinical symptoms. And this is maybe just a pancreatopathy. So the argument that the specificity limited by that doesn't dissuade me that EOS isn't ready for prime time. Perhaps the biggest thing is that EOS's major challenge is its inter-observer variability. Whereas with an MRI and a CT, you can take an image and you can share it around, and it's easily transmissible. So you can have many people look at it and agree or disagree on the quality and the morphology. Whereas up until now, we've really had to take the EOS operator's word based on their report and based on those horrible looking little pictures. And I think, if we borrow from our radiology colleagues in transabdominal ultrasound and that data is cheap, we really need to move, in order to move EOS further forward and make it a little bit more widely acceptable. And I think the biggest Achilles heel is the inter-observer variability. We need to be moving more towards video, standardizing video pictures of our EOS. Easy to save now, data is cheap. And I think as a consequence, we can then more routinely compare imaging studies and not just take other people's words or our fellow colleagues' words for it. So I think that the question of is it ready for prime time? Well, I think it's a valuable tool. It's widely available. It does detect subtle changes. It's highly sensitive. It does correlate to histology. It has a lot of potential, like MRI and CT and other modalities, where we can use it as a platform to go beyond B mode. We can think about how do we use it in conjunction with tissue biopsies, elastography, contrast enhancement, and like all the imaging modalities, the role of AI. It is invasive. We do have to overcome this hurdle of high inter-observer variability, and cost might be an issue. And with that, I'll thank you for your time and attention, acknowledge my team. Thank you very much.
We could ask our speakers to join us on stage, and we'll take some questions from the audience for a panel. Are we able to get our speaker from India on the Zoom?
Yeah, I'm here.
Dr. Whitcomb.
So I really enjoyed this session a lot. I had a comment for Dr. Little's presentation, and then a question, a statement, and something else for Dr. Park. Back in the 90s, we did a number of studies on rats, giving them different levels of alcohol for different durations and those types of things. And then we did a type of transcriptomics called differential display to try to figure out what's going on. We were shocked, as you were, to find that in rats that drank high doses of alcohol, their pancreas appeared stone cold normal. However, on electron microscopy, it was obvious that the mitochondria were dilated and the cristae were broken and they were just in turmoil. But when you looked at the gene expression, the components to build new mitochondria were sky high, and it looked like there was a steady state where the mitochondria were being damaged and cleared out, but the rats were able to compensate for that by making mitochondria fast enough to maintain their function. So it's really interesting how much the body can compensate for injuries until key pieces are missing, maybe phosphates and others, and then it can't. So I've been thinking about this for quite a while.
Yeah, no, that's a very interesting observation. I suspect that that's right. We're sort of at a threshold between not getting pancreatitis and getting pancreatitis in heavy alcohol users. Yeah, that's very interesting.
My statement and question for Dr. Park relates to one of the papers that Dr. Yadav wrote with me. We were in an international sword fight and bloodbath about how to not only diagnose early chronic pancreatitis, but how to define it. And the problem is that EUS can identify abnormalities, but you have to understand the biology that leads to those changes, because many of the, in many cases, the changes can be reversible. Sometimes they progress, sometimes they don't. So the context turns out to be very important. Some of the groups, especially in Japan, that felt that the diagnosis of early chronic pancreatitis was 100% accurate was because the people making the diagnosis were not pancreatologists. They were radiologists that did the procedures, and they felt like what they saw was the gold standard and everyone should comply to that. So I think that the most important issue about early diagnosis is you're seeing abnormalities, but the interpretation is dependent on the context. You need to look at the trajectory, the risk factors, and the differential diagnosis. And by looking at that, you can make a determination with a high degree of accuracy as to whether or not the changes in this case are early chronic pancreatitis or not versus another case. And so it's more like more of a detection of an abnormality without being able to define what the process is without that context.
And I would agree with you in that sentiment or that enigma, that the need to clinically correlate versus just strictly relying on morphological appearance. I think that my hope is that studies like PROCEED, that as many of us are in, will, and if we do serial type of imaging, will be able to better identify which features are predictive over time, and when and tell us then looking back which ones really mattered.
Right. So I have absolutely no criticism for your presentation, because your job was to review the recommendations, which you did in a very excellent way.
Thank you.
Yeah, I really enjoyed this session as well. And, as I was getting more interested in micronutrients in pancreatitis for various reasons, and now obviously solutes such as phosphate, I wonder whether many of the other types of problems or risk factors leading to pancreatitis might be triggered by malnutrition or a reduced energetics type of situation. One of them is valproic acid. And, valproic acid rarely causes pancreatitis, but it's usually a severe pancreatitis when it happens. It usually happens, it's given in children who are usually neurologically impaired and often malnourished. And we've given valproic acid to mice up the wazoo and not had any evidence of pancreatic injury, but you wonder whether it's because you need to trigger the lack of ATP or bioenergetics or micronutrients of some type, which is why I think general commentary I was wondering about is whether in general we should be taking more strict dietary intake prospectively in many of these studies to look at the impact of micronutrients.
Very good point. I suspect that most gastroenterologists probably don't take a very detailed dietary history, but we know that alcoholics oftentimes substitute alcohol for dietary calories from other nutrients. So yeah, I think it's a very interesting observation about valproic acid.
We're running out of time. Just maybe a couple of quick questions and points, if that's okay.
Okay.
Thank you.
I waited until now instead of from the other acute pancreatitis.
We will take your question.
I'm not a doctor, so you could relax on that point. However, 27 years of designing and doing studies in the chronic pancreatitis area, I think gives me an opportunity to say something, including the PROCEED study right now. We're still funding that to an extent. What I want to say is that, first of all, chronic pancreatitis, all of you have done a good job over all the years. I mean, all the technology and going up from a consistency of a statistician being able to define the case report forms so that we know what we were, at least know what we know. But where the problems with your group is to try to decide when there's enough damage to the pancreas that you could say it's chronic pancreatitis and not acute. Well, that's fine. That's your arguments. I'm not going to get involved in it. But what I'd like you to do is to share your expertise with the ones that are doing acute pancreatitis so they understand that it is important to have standard of care for acute pancreatitis defined so that insurance companies know what they pay. And people like me, when I want to support a study that you want to do, don't have to pay what the insurance companies should have to pay. That's very important because, like, for example, in the acute pancreatitis state, is that we have to get informed consent for even the basic things that in the chronic pancreatitis area is accepted by everybody. And that makes it almost impossible to just collect zero data. In other words, data with placebo only. I have a study, I spent $170K and I got 5 patients with no drug. And I still don't have the data. And it's been 3 years. Well, 4 years. Started about the time when George was involved in the starting of his study. Same place. What we have to do is be smart. There is certain clinical findings or chemical findings, physiologic findings that we want to know about the pancreas. Let's find it out. We'll find it out in acute pancreatitis. We need your expertise to set a standard. I'll support the studies that would go forward with that particular position.
Yeah, that's a good point, Dr. Purich. So for acute pancreatitis, Melina had actually mentioned yesterday in our talk, there is a prospective observational study in patients with acute pancreatitis that actually is going to be launched this month as part of the NIH consortium, which is the first longitudinal study of such kind other than what George just completed, the PAPE study. This is going to follow patients on a regular basis with dedicated evaluation. And in a subset of patient, morphologic assessment of the pancreas is going to be made on a regular basis to assess for changes that are occurring in the pancreas and how they associate with outcomes.
Well, you understand that it has impact with you, what they do in acute pancreatitis.
Correct.
For example,
Yeah.
that protocol that we were doing at 2 institutions, I won't mention them, had chemokines, interleukin profiles in it because they were trying to find out that information. Well, it'd be nice that if all the standard of care, since the standard of care in acute pancreatitis is loose, so to speak, between institutions, to get an acceptance level, let's do a profile of some sort. We could change it each year once you know certain things statistically don't correlate, logistic regressions, whatever. But we're not learning anything. All we're doing is we're just jumping into here or there, spending lots of money on setting up a protocol for the background stuff. We should be doing that for, like you do in the chronic pancreatitis area. You're looking at a new EUS test, CT, MRI, what's going to be, some of it could be use of secretin, the drug that I have for collecting pancreatic fluid and do proteomics on it, who knows? But you don't have to, when you do all of that, start off with the protocol in the background of what is considered the standard safety data you want to know about the patient, which the insurance company should pay if you're normally doing that for the care of the patient. Okay?
Thank you, Dr. Purich. We're going to, in the interest of time, I'm terribly sorry, we're going to have to end questions now as we have another session coming on. I'd like to thank all our speakers today for your time, and we'll move on to the next session.